Good morning, good evening, wherever you are dialing from.
Hello, hello everyone.
Yes, we will wait like 2 more minutes for some other people to join us, as I can see the interest for the webinar is enormous tonight. So, as always, please write in the chat where you are from so we can say hello. I got a special request to say hello to our doctors from Philippines. I don't know if you are here, Jenny, and the team, but yeah, that was a special request to greet you on a live session. Egypt, Bulgaria. Yes, you will have the access to the recorded webinar afterwards, yes. Taiwan, Italy, wow. So we are live globally. We are everywhere. Oh, we've got United Arab Emirates as well. Hello, hi. Kiev, Bergamo, Peru. Loads of people, actually. Amsterdam, Abu Dhabi. So do you think we can start?
Yes.
Okay. So once again, welcome to our webinar. I'm Monika Milewska, and I'm representing Metrum Cryoflex. Today, I'm pleased to introduce to you Dr. Michał But, a specialist in anesthesiology and intensive care. He's an active member of ESRA, European Society for Regional Anesthesia and Pain Therapy, International Association for the Study of Pain, and Polish Neuromodulation Society. I've got a pleasure to greet you, to have you today with us, Dr. But. So one kind of comment in terms of the organization of our webinar. Dr. But is Batman. No. Maybe he can fly, but I don't think so. So in regards to the chat, as always, please, if you would like to ask a question, write it in the chat during our presentation. And please remember that every single question to be introduced after the presentation as a question needs to be finished by the question mark. So please make sure that the question mark is in the end of the question. Every single person will receive the certificate, of course. If you registered with the correct email and name and the surname, because sometimes it happens that you put a wrong name, but yes, everyone will receive it. And of course, the recorded webinar as well. If you need anything else, please let me know. I will be here all the time in regards to any issues you're going to have, or I do hope that you will not have. So I think that we can start. And yes, once again, welcome. Michał?
Hello everyone. My name is Michał But. I'm pain physician from Poland. I'm very happy that there is so big interest in this webinar. This is one of my favorite pain treatment technique. I'm doing this for about 15 years, but now I can see there's more and more people are interested in performing this technique. So in this webinar, I will talk about some indications for the cryoablation. I will tell you about the physics. I will give you some advices how to increase the effectiveness of the technique. And I hope this will be useful for your daily practice. So I will start with one of the best research indication for the pain is this freezing of the intercostal nerves. This can be used for both the chronic and acute pain. For chronic pain, post-carpatic neuralgia is the great indication for cryoneuroablation of the intercostal nerve. But here is the example of the acute pain treatment, the funnel chest operation. This is operation performed on 11, 12 years old patients, or very young patients. Before the treatment was introduced, they had to stay in the hospital for 5, 6 days. They used a lot of strong painkillers, including opioids. So after the cryoablation of the intercostal nerves, they can go home next day after the operation. There is a 19-fold reduction in opioid consumption. So these are fantastic results which can be achieved with the freezing intraoperatively of the intercostal nerves. So I will tell you in the lecture, in the webinar, about the pain treatment personal approach. Because if you want treat patient with a chronic pain, you need to treat every patient individually. I will tell about the history of using cold to treat pain and the mechanism of action, equipment which is needed for the procedure, description of the procedure, indications, and on the end, the clinical examples. So you have three main neurodestructive techniques available. So there is a thermal ablation, cryoablation, and the neurolytic blocks. So this is not about the cryoablation is best. You just have to know every techniques to treat every patient, because every treatment has his own advantages and disadvantages. So for the example, thermal ablation is very, very precise. So, like for the trigeminal nerve ablation, this is what like method of choice, because you want to be very, very precise. Cryoablation has bigger area of action, but it also may cause bigger collateral damage. Neurolytic blocks has the biggest area of action, and this is like method of choice for the celiac plexus neurolytic blocks or superior hypogastric plexus block. No other technique can be used for this kind of pain. So you need to know every technique to pick right technique for the patient, because every patient is different. So you need to start to how to pick the perfect treatment method for the patient. You need to start, of course, with the detailed history, and then you draw some conclusions from the history, and then you think about the examination of the patient, and then you need to perform diagnostic block before any neurodestructive technique. This diagnostic block gives you the chance to confirm your thoughts about possible cause of pain, because with the use of the cryoablation, you are able to stop the conduction of the pain signals. You need to choose which nerve is responsible for transmitting those signals. And of course, you're not starting with the most destructive technique. You start with the least invasive, and then go to more and more invasive techniques. So you start with the block, with the steroid block. You can use stimulation, transcutaneous stimulation, like FSM, frequency specific microcurrent. This is also the treatment method for the chronic pain. Then you do the pulsar ref of the nerves, and then you go for the cryo, thermal, or chemical destruction with the neurolytic blocks. So you need to remember that every technique gives some advantages. So after neurothermal ablation, you may expect the duration of the effect like for 6 to 12 months. Similar for the cryoablation, may be a bit shorter, and for the neurolytic blocks also about half year of improvement. What is the history of use cold? So this is the techniques used for the very, very a long time. Already ancient Egyptians used cold compresses to relieve pain, and every of you know that if you use ice cold bath, after several minutes your skin will be numb. So this is one of the mechanism of stopping the conduction of the signals from your skin. So they knew this as many years ago, and use it as a painkiller. And also Hippocrates described not only analgesic effect of the cold, but also anti-inflammatory effect of the cold. This is the difference between thermal ablation, when you have to put steroid after ablation of the nerve, and after cryo you don't need it, because cryoablation also acts as an anti-inflammatory. So the first modern device was made by James Arnott. It was in 19th century. So he used cold for to treat small operation, and that was like answer for the overuse of chloroform, because overuse of chloroform, which wasn't well known, caused several deaths. So that was the answer to anesthetize the dental procedure or small surgical procedure where you didn't need general anesthesia. The modern cryoanaesthesia was developed in 1961, when where on the end of that small tube temperature of minus 190 degrees of Celsius was achieved. So that gives you more precise treatment. You could be close with this first probe to the nerve you wanted to treat, and you could freeze this nerve. And Amwa also developed one device in 1967. He achieved minus 70 degrees on on the end of the small tube. And there are several names for the treatment of the nerves. So the mostly used is cryoneuroablation, because your target are nerves. So when you ablate the nerves, this is called cryoneuroablation. So the main goal is to stop the transduction of the pain signals. So where you freeze the nerve, which is responsible for transmitting pain signals, you are able to stop or reduce significantly pain. And what is used on modern devices? So we use Joule-Thomson effect, where the pressurized gas is transmitted to the small inner tube, and it goes through a very small hole on the end of the tube, and exhales to the outer tube. And this reaction is endothermic. The temperature close to the active tip of the probe drops significantly, and depend on the gas used on the probe, you can achieve minus 80 degrees for the nitrous oxide and minus 60 degrees for the carbon oxide. So you are able to stop the nerve, to stop the conduction completely, because the total stop of the conduction is at the minus 20 degrees. Of course, all the modern probes have a built-in nerve stimulator, where you can prove close proximity to the nerve with the sensory stimulation. You can also exclude proximity to the motor nerve, like for proximity to the lumbar or cervical nerve root, where you cryoablate medial branches. So you can exclude close proximity to the roots with the motor stimulation. And as you can see on this picture, on the end of the probe, there is a ice ball formated, and you can see the breaks on the ice. And this is very important. Those breaks has also role in the stopping of the nerve conduction, because when the ice melts, it breaks. So the nerve inside breaks also. This also allows to increase the effect of the cryoablation. So this is very important to wait until this ice ball melts completely, because in modern devices you use double freeze and one defreeze uh, in one treatment. This is very important to wait until this ice ball melts completely. So very important defreezing time. As from the researchers at the 10 Celsius degrees, larger myelinated fibers stop conducting, but there is a total stop of the conduction at minus 20 Celsius. So as you can imagine, this ice ball has inside like minus 80 or minus 60 degrees, but on the edge of the ice ball, there is a zero. So if the nerve is on the edge of the ice ball, it won't stop conduction completely. So you will have pain return after several days or weeks. So this is very important to use some kind of guidance like ultrasound guidance or fluoroscopy guidance, and also to confirm close proximity to the target nerve using the sensory stimulation. Then you are 100% sure that you are very close to the nerve root, like 1 or 2 millimeters away, and you are able to freeze the nerve completely with the minus 20 degrees. There is also autoimmune phenomena involved because the release of proteins may trigger our immune response and to the target tissue. This may also explain the prolonged effect of the cryoablation. There is also this destroy of the vasa nervorum. This is causing Wallerian degeneration of the nerve and also prolongs the duration of the reduction of the pain. And as I mentioned, the cryoablation has anti-inflammatory effect, so you don't need to put steroid after the procedure. And now will be several very important slides for you to remember what you need to do to increase the effectiveness of the treatment. So as I mentioned on the beginning, you need to be as close to the target nerve as possible. So use ultrasound guidance or fluoroscopy guidance, and also confirm with the sensory stimulation. So you don't anesthetize the nerve before you stimulate. You stimulate the nerve. You actually don't need to anesthetize small nerves like medial branches. You need to anesthetize sometimes larger nerves because this may be painful for the patient for like half a minute. So you, after the sensor stimulation, you need to put another needle and inject local anesthetic. But for most of the nerves, there is no need to anesthetize before the procedure. Pick the right probe because you have several probes available. You can pick smaller probe for very small nerves and larger probe for larger nerves because you increase the size of the ice ball with a thicker probe. Consider the characteristics of the tissue surrounding the nerve. So if there is a lot of vessels, they act like heat exchangers. So they take away the cold from the probe. So you won't have the ice ball as you expect. So think about finding the nerve where it's not lying on the artery or on the vein, especially on the artery. So move your probe, ultrasound probe away, so the nerve is not very close to the artery because you won't be able to freeze it. And for example, if there is an inflammation, there is also increased blood flow and the temperature may be increased, so the ice ball won't be that big as you expect. Remember about these 2 cycles. So you need 2 cycles and the freezing time between them. And from my experience, 1.5 minutes is enough for most of the indications, and 2 minutes of freezing is fine. I've heard 1 week ago that there are proofs that 3 minutes is optimal because this increased the duration of the damaging of the nerves. So if the paper will be available, that maybe that will change to 3 minutes freezing and 2 minutes the freeze time. If you use ultrasound, use color Doppler to see the blood flow surrounding the nerve, because this gives you some information about the possible size of the ice ball. So if there is an increased blood flow, as I mentioned before, the ice ball won't be that big as you expect. And equipment which is available. So there are major three major cryo machine. There is one from the Epimet, very new. I didn't see it. You have several probes available with the sharp and the blunt end and different sizes of the probe. You have Inomet machine with mainly two different probes, 1.3 millimeter and 2.1 millimeter and 15 and 150 millimeter length, and one which I used Cryo-S painless from the Metrum. I think is very good because it's very intuitive, very easy to work with. And the main advantage of this machine is the number of probes available. So you have very different probes for different indications. You can pick the probe especially designed for the intercostal nerves. You can pick the probe designed for the cryoablation of the genicular nerves, and the one with I like most, designed for the sacroiliac joint denervation. And you can of course pick from the sharp and the blunt probes. The difference I expect you now. The main difference is with the blunt probe. Uh, is it possible to build some ice ball around the tip? If you have sharp probe, the ice ball will end on the tip. If it's round, the ice ball will be a bit far from the tip. So if you want to target nerve perpendicularly, it is better to use blunt probe. If you can be parallel, use the sharp one, because you don't need to cut the skin or use the introducer with the sharp probe. The procedure description, of course, you start with the anesthetizing of the skin with the local anesthetic. For the blunt probe, you need to use intravenous catheter as a guide, and advance the guide slightly, but not end on the nerve, because you need to be aware that the film on the catheter, this will stop of formation of the ice ball. So you need to be away from the catheter with the active tip of your cryoprobe. If you are using ultrasound, of course, use your guidance to end up with the active tip just close to the nerve. And use the stimulation, especially when you start with the procedure. I encourage you to use the stimulation to confirm the correct placement of the probe, because if there is a stimulation above zero point 0.8 volt, you are 100% sure you are close enough to freeze the nerve completely, because that gives you information that you are not the nerve is as close as 2 millimeters to the probe. So if you have stimulation over 1 volt, you need to change the position of the active tip and try to stimulate again. If you're not sure, if you are close to the motor nerve, like nerve root, use motor stimulation to exclude proximity to the nerve root. And the next, of course, 2 cycles, 2 minutes with 1.5 minute defreeze times. Maybe in the future there will be some proven information that you need to use 3 minutes freezing time. And about the frostbite, if you use the cryoablation for the very superficial nerve, there is a very small, very easy method to avoid frostbite of the skin. Just put your thumb in the glove. For example, if you freeze supraorbital nerve, put your thumb over the skin above the active tip, and that's it. You won't have any frostbite, because you hit from your for your thumb is enough to hit the skin of the patient, and that's it. And indications for the acute pain, as I mentioned, the most research is the freezing of the intercostal nerve. and the funnel chest operation is one of it. But also for the rib fracture, if you have severe pain after rib fractures, and this reduces the possibility of breathing, you can freeze the intercostal nerve, and there will be pain. Patient will be pain free for 4 or 6 months, and this is great indication. Uh, Another thoracic surgery is also the good indication, but and also chronic postoperative pain after thoracic surgery. And you know that up to 50% of the patient may suffer severe postoperative pain. You can freeze intercostal nerve and reduce the pain very significantly. Cryoablation of the suprascapular nerve. I'm not sure if every patient is good indication for this procedure. You need to be aware that in most of the cases you will have some reduction of the motor function of the supraspinatus muscle, so you need to consider it very individually. Cryoablation of the infrapatellar branch of the saphenous nerve. I think this is good indication because this nerve may cause a lot of chronic postoperative pain. So if you pick the patient where there is an increased risk of chronic postoperative pain, I think freezing of the infrapatellar nerve may be good option, and also freezing femoral branches traveling to the hip joint is also good indication for hip operations. And chronic pain. So in one sentence, every pain where you can localize or identify the nerve which is responsible for transmitting the pain signals, you can freeze it and you will have pain reduction. One of indication I use it I most is the sacroiliac joint pain, but facet joint pain and freezing the medial branches is a great indication. Coccygogenia, peripheral neuropathies, phantom pain, painful neuromas. All those indications are great for the cryoablation, and the result is fantastic in some cases, and you can have up to 1 year of reduction of the pain. So there is a lot of indication. When you start using cryo, you will see more and more indication for this procedure. And here you have some examples of the cryoablation. On the first picture is the cryoablation of the suprascapular nerve. So if patient have complete tear of supraspinatus muscle, you can freeze it with no worry about reduction of the pain of the movement because in these cases patient cannot elevate the hand above the shoulder. So when you freeze the suprascapular nerve in this patient, they won't be able to see the difference. In frozen shoulder, patient like cannot move a hand at all. After cryo, they can move the hand 19 degrees straight away after the treatment. Genicular nerve cryoablation, of course, that this is a great indication. You use ultrasound guidance for this procedure. You start with the longitudinal view, find the right spot to insert the probe. You anesthetize the skin, then you change to the cross section, and you can see in plain view of the probe lying on the bone, and you can freeze 3 genicular branches, but of course this is not only sensory nerve of the knee. You can also add the infrapatellar branch to have the better result. The hip sensory nerve cryoablation. So the first target are nerves traveling from the femoral nerve. So here you can see the young patient with the bilateral pain of the hips after first treatment. That there was 4 month pain relief. After second treatment, there was 9 months of pain reduction. So great result of the technique, and you can see from this example is repeatable. and you can even achieve better result with the next procedure performed on the same patient. So this is slightly different with the thermal ablation. After several treatments, the nerves do not regenerate the same way, because with the cryoablation the perineurium remains intact and the nerve regenerates within the perineurium. With the thermal ablation you destroy the nerve and he builds like the net surrounding the target. So after several thermal ablation, it is really difficult to achieve a similar effect like we started. So with the cryo, you can repeat the procedure like 10 times with the same result. Here's the sacroiliac joint cryoablation using the curved probe. That was like prototyped. I used this probe like 10 years ago. I can remember that was the prototype. Now the probe looks slightly different, but the mechanism of action is the same. You are able with this probe to freeze everything lying between the S2, S1 and S3 foramen and the sacroiliac joint. You need to use ultrasound and fluoroscopy to perform this method. You can see the probe lying just on the dorsal part of the sacrum, in between S1 and S3 foramen. The results are perfect. But you can cryoablate sacroiliac joint in the simple way. I am starting with this one, using normal straight probe at the level of S2 foramen, lateral to the S2 foramen, because there is the perisacral neural network is most dense on the level of S2. If I'm able to freeze those nerves, in most of the cases, the patient don't need the curved probe, because it is more complicated. You need to use fluoroscopy than ultrasound. With this one, you just need to use ultrasound, and really most of the patients are happy about this. Here's the example of the medial branch cryoablation. You can see the probe in between transverse process and the facet joint. You need to remember that you need to be cranially on the transverse process, and the size of the ball is much larger than the size of the lesion with the thermal ablation. So you don't need to be that precise with the same effect. So you may use ultrasound for this technique. Clunal nerve cryoablation. So this is very common nerve entrapment syndrome. You can use cryoablation of the clunal nerves to have great result. If you perform diagnostic block of the clunal nerves and the pain is gone, you can freeze it with a great result. You can perform this technique bilaterally. And here you have example of the lumbar nerve root cryoablation L4. You need to remember this is the palliative treatment. So if patient cannot walk before the procedure, you can do this. If patient has no motor deficit, you cannot freeze the nerve roots, because you will cause cause destruction of the motor function of the nerve root. So you need to remember only palliative care, but there is a lot of indication. In this example, there was a nerve root compression by the tumor in the muscle, compressing the nerve root close to the foramen, and I just freeze the dorsal root ganglion of the L4 with a great result. And here's the example of the thoracic medial branch cryoablation. You put the probe on the dorsal part of the transverse process, and you freeze the nerves. Of course, if you want denervate one facet joint, you need to do the procedure on at least 2 levels. And here is the intercostal nerve root cryoablation. You can approach intercostal nerve on several levels. You can start with the dorsal root ganglion cryoablation, but you can go more and more distally for different indication. This is also palliative indication. That was a tumor in the costals, causing severe pain in the chest. So you need to remember, you need to freeze the nerve above the cause of the pain, because if you freeze the nerve distally, you will have numb skin and the pain. So for the every entrapment, you need to freeze the nerve above the entrapment. And here's the example of the freezing of the intercostal nerve in patient with the post-carpatic neuralgia. This one you can perform with the ultrasound only, with the blunt probe, with the great result. And occipital nerve cryoablation for the cervicogenic headache, uh, only in a case where the pulse RF is not effective, because most of the patient are happy with the pulse RF. After the pulse RF, the skin of the head is not numb. The patients tolerate it better than the cryoablation, but especially in occipital neuralgia, where there is a severe lancinating pain in the head, pulse RF may be not effective, and then you can choose cryoablation. Cervical medial branch cryoablation, you can see the patient. You just target the medial branch on the articular pillars of the cervical region. You can see C2, C3 medial branch. You can see facet joint of C2, C3. There is a third occipital nerve, another target for the cervical genic headache, and the cryoablation is very effective. Here is the third occipital nerve cryoablation. Because it has larger area of action and it can be repeated several times, it is better than coagulation of the nerves. Of course, you start with the least invasive, like pulse RF. If it's not effective, you may cryo it. And the sphenopalatine ganglion cryoablation is not very often indication for the cryoablation, but sometimes where you cannot reach proper stimulation with the thermal ablation, and you're afraid of ablating the palatine nerves of the maxillary nerve, because you don't want to have this burning sensation in the mouth after thermal ablation. You may use cryoablation, because you will have this anesthesia in the mouth, which will be relieved after several weeks, but you will achieve cryoablation of the sphenopalatine ganglion. So this may be the method from some of patients with the headache, especially where you cannot achieve very specific thermal ablation of the sphenopalatine ganglion. Distal branches of trigeminal nerve. In this case, you use very small probe. Remember about the frostbite risk. So put your thumb above the active tip of the probe, and you can use shorter duration of the cryo, like 1 minute with a half minute of the freeze time, and that will be enough. And greater trochanteric bursa cryoablation. This is indication of the cryoablation of enthesopathies. Cryo is good indication for all enthesopathies, because you cryo all the sensory innervation of the ligaments, tendons, bursas, and that's why you stop the pain, you stop the signals causing the pain in this kind of the indications. So thank you very much. You can see the great background. It's not fake. It's actually real. I'm traveling back from the total south of the Poland, traveling back home. I found this perfect spot for you. You can find me on the LinkedIn. I encourage to follow me. You will be able to find some interesting materials every week. Thank you.
Thank you so much. We've got a lot of questions, and yes, the background is real. It's not a wallpaper. So we've got quite a webinar today. And first of all, please accept our apologies for any inconvenience you sort of encountered today. We will send, of course, the recorded webinar. First of all, you will receive the link at once after the webinar, but then once again, you will resend it a bit, cleaned. So So you'll be able to see everything once again. So let's go with the questions. Yes, as I said, you will
Yes.
achieve it. Yes, the slideshow. Okay. Do you want me to read it, or you're okay?
I'm trying to. Okay, cryoablation is being used
Okay, so maybe I'll do this.
for the. Yes.
Cryoablation is currently being used in veterinary medicine in cancer patients for the removal of tumors. But do you have any knowledge or experience of the use of cryoablation in the treatment of veterinary medicine for acute and chronic pain?
So, if you are comfortable with the finding nerves in animals, you can cryoablate them because you just need to perform diagnostic block. I don't have any experience, sorry, but if you can use ultrasound and you can see the nerves which may be responsible for the transmission of the pain signals, and you perform diagnostic block and you can see improvement, you can cryoablate it. That's not a problem. Just you need to have some experience in finding the nerves which may be responsible for transmitting pain. So intercostal nerve, I think they are similar in the horse, for example, like in the human. So they lie in the same position, so you can freeze it. But I don't know about another indication. But the sacroiliac joint also. So of course I think but you can be pioneer of this because you cannot find a lot of papers in humans. So I am assuming you won't be able to find anything in veterinary medicine.
Just to add on top of it, we've got some doctors in Brazil who have been already experiencing and who have been conducting cryoanalgesia on horses. So yes, that
Okay.
is possible.
Yeah.
Does unfreezing time promote post-cryo neuritis?
Does freezing time promote?
Unfreezing time.
There is actually no neuritis. This is one of the main advantage of the cryoablation. So because this acts as this has anti-inflammatory action, you don't have neuritis. The nerve regenerate. So the only problem you may find after cryoablation is not the proper spot for the cryo. So, for example, if you have nerve entrapment syndrome and you freeze the nerve distantly from the entrapment, you will have severe pain with the numbness of the skin. So one of the examples is entrapment of the lateral cutaneous nerve of the thigh. You need to be cranial from the entrapment, so it is very difficult to perform this. So be very cautious, but you won't have neuritis. I think the circles we use, so up to 3 minutes, won't cause any damage to the perineurium, and the nerve just regenerate inside it. So you don't have any neuritis. You don't need steroid to inject it.
Okay. This one. Dear Michał, thank you for the lecture. I'm using Cryo-S painless to treat phantom limb pain associated with neuromas. Typically, it is painful neuroma of sciatic nerve or its branches, which stops the patient from using their prosthetic. Question: is it reasonable to ablate the painful neuroma, the nerve proximal to neuroma, or both?
So only neuroma itself or the proximal to the neuroma. So I'm freezing very close to the neuroma. If the neuroma is big, you need to remember you need to freeze it on the several sides. So for very large neuromas, you need to be above, below, from the lateral and another side. This is crucial because if you freeze half of the neuroma, you may have increased pain. So sometimes it is better to find the spot just more proximal to the neuroma because the nerve is smaller, and freeze it just from the two sides. This is very, very important to freeze it completely. So you don't have two circles, like sometimes you need to have 8 circles just around the tissue you want to target. So sometimes I'm freezing just proximal to the neuroma.
Okay. With cryoablation in neuroscopy, I cannot read it. Illness, post-trauma, medular. Thanks. That is quite a question. Yes. Some
I
spelling
don't know.
mistakes.
Neuropsychology. Yes, I need to use internet to find what it is.
If you could please ask about,
Requimedular.
please check your question, then we will be really happy.
Requimedular. I don't know what is.
Okay, let me go with another one. What is your success rate with painful neuromas?
So as far you are as you are able to freeze the nerve completely is 100%. Of course, if the neuroma is very large, the you may not be successful because you not freeze it completely. So be careful of this and be aware. Use a probe with a larger active tip and freeze it around. And it is better to freeze it just proximal to the neuroma because your nerve is usually smaller, and that's fine. So if you have like mortal neuroma, which is small, you just putting your probe, and it's very important. If you can target neuroma parallel, it is much better because this freezing distance is much bigger. If you target your nerve this way, you may freeze just very small portion of the nerve, and that's why you may not be successful. So for the Morton, I'm going with the probe like this, just between the fingers here, yeah, like this, with the fluoro and the ultrasound, and put the probe parallel to the nerve, not this way. I started this way and found it that I wasn't successful, or the pain returned after 2-3 weeks. When I started to do this way, I have much better results.
Okay. In the genicular, you go perpendicular as in the photo.
So this is the bone. I'm going this way. Yeah. So there is the nerves are not traveling in the same way. So from the anatomical findings, I'm not using the nerves on the shaft close to the artery. I'm going more distally. There is a more of the sensory nerve, and I'm going like this, yeah, with the probe.
Okay. Despite the fact that any motor injury would be well tolerated because of the shoulder stiffness, did you in fact observe any motor impairment at all following cryo?
So actually, this is very interesting because I could expect the motor function will be in some way affected, but those patients can move the head more after the procedure than they were able before. And there is also explanation for this because you cryo the small sensory nerve. The motor nerves are bigger in diameter. So even if you affect the motor function, it will return after several days or weeks. But analgesic effect will last for longer.
Okay. Should cryoneural lesion be performed after endoprosthesis or only before surgery?
This is good question. I would be very cautious to do this before the operation because I don't think this is good to perform for every patient. You know that of course if patient is waiting for the alloplasty, you can do this because it gives him pain relief for several months. But just before the operation, I don't think this is good option. If you have patient with the chronic with the acute post-operative pain, this is good option for the patient. But I'm not great fan of pre-operative cryoablation of the sensory nerve.
When does the effect occur after cryoablation? Is it possible to avoid loss of motor function?
Yes, because in most indication you just target sensory nerve. Of course, every nerve has some very small motor function, but in most of the indications, like for the medial branch or for the sacroiliac joint, there is no not motor deficit at all. If you freeze the uh, suprascapular nerve, there may be some loss of motor function, but it returns very early. And but if you want to target just the sensory nerve, you're not freezing the nerve in the suprascapular fossa, but slightly away and lateral, and there is only sensory innervation to the shoulder.
Okay. Can you perform cryo at thoracic levels in a palliative patient with infiltrative lesion in vertebral canal?
No, if there is a infiltrations to the intervertebral canal, you cannot freeze. Of course, if the pain is transmitted through the ribs, but be careful. Perform diagnostic block because sometimes the pain is just transmitted to the ribs, but the source is in the intervertebral canal. So in this situation, you won't have a result.
How are the results with the phantom pain?
Yes, the results are great. If you do the diagnostic block first, if there is a great response, freeze the nerve.
What is the recovery time if there is a motor involvement?
Depend of the size of the nerve. But as I told you, you mainly target sensory nerve, so there is no motor disturbance.
Can we use it for celiac
No.
safely?
Oh, very good question. No, unfortunately, no, because of several reasons. One reason is the anatomy. It lies just above the artery, close to the celiac trunk. So arteries all around it. So you are not able to freeze it completely. I'm using neurolytic blocks for it, and it's perfect.
Can we cryo small metastasis?
Yes, this is it, and the indication for the oncology, and because of the autoimmune phenomena, there was proven that the life expectancy of the cryoablation of the metastasis is bigger than with the surgical removal.
Neuritis rates?
If you freeze completely, no. If you freeze proximally to the cause of the pain, no. But the I have actually I can remember about one complication when I freeze the lateral cutaneous nerve of the thigh in wrong place, and there was a pain with the numb leg, and that's it. If you pick the nerve correct, perform diagnostic block, there is no neuritis. Of course, you may damage the nerve mechanically. Yeah, if it's on the bone and you just put the probe like this, you may damage the nerve and you may have neuritis. But with the ice ball, no.
The next one. If colored Doppler reveals a prominent intercostal artery running tightly adjusted to the nerve, do you rely on real-time sonographic ice ball dimensions alone to confirm a complete
So
conduction?
no, because you just want to slide the probe below the rib, and you actually can see just small portion of the ice ball. The rest is hidden below the rib.
Okay. For phantom pain, at what level do you do cryo? Only in the neuromas?
No, no, no. For example, if I have leg, I'm doing like for the femoral nerve block or the sciatic nerve on the buttock region or just above the ligament. I'm doing the block and I'm freezing there. In most cases, there is no neuroma.
Okay. A patient with a scapular fracture 1 year ago is experiencing debilitating shoulder pain. Is ablation possible? And if so, which nerves and approach would be necessary?
So you need to perform a diagnostic block. So the suprascapular or dorsal scapular nerve. If you have pain reduction with one of those nerves, freeze it.
What about local tissue hydration related to the bone?
So I'm using local anesthetic before the cryo because I have really big experience in this procedure. So I'm not stimulating in most situations. So I'm using local anesthetic, and you can use 5% glucose also to increase the size of the ball. So for this is the good example is cryoablation of the femoral sensory branches of the sensory branches from the femoral nerve to the hip joint. You put your needle below the inferior anterior iliac spine on the iliopubic eminence. You inject the local anesthetic or the 5% glucose, and you just remove the muscle from the bone, and then you put the probe in this space, and there is a bigger ice formation because that's not ice ball.
Is it possible to do it only in the clinic or not, and not in the surgery room?
Of course, 99% I'm doing in outpatients.
How long does the analgesia obtained by this?
Depend how long you can freeze the nerves, on how big distance. If you go like this, up to 1 year. If you go like this, 4 months.
Would you recommend cryoablation for Morton's
Yes,
neuroma?
yes. I do this for the Morton's neuroma.
Good.
I start with the pulsar ref. Of course, this is really great therapy, but in some cases it just doesn't work. So I cryoablate it.
Cryoablation of soft tissue tumors and metastasis is described in the radiology literature. What is
I'm
your
not.
experience?
I'm doing this only for pain, but I know from papers that there are great results.
Oh, that will be. Is this procedure more effective than nerve dissection?
Everything depends on the patient. So you need to pick right procedure for the patients. You know, you cannot cryoablate every patient. For some patients, the physiotherapy is okay. Or your collagen injection is okay. Hydrodissection is okay. You just need to do. That's why I showed you on the beginning. You need to find the right treatment for the patient, and when you find it, you will be successful.
For spasticity, is it better than RF?
I'm not using a ref at all for spasticity, but cryo, I know it's fantastic. I saw the lecture on last Saturday, and the patient were crying after the procedure with 1 year reduction of the muscle stiffness is fantastic. It's time consuming, I can agree, but it's really fantastic.
How fast full analgesia develops after cryo if you use it for postoperative analgesia after thoracic surgery?
Straight away. Straight away. You have the effect just after 15 seconds.
What about outcome in complex regional pain syndrome?
Um, I uh, I don't have too much experience with this indication. So I'm because mainly my target is sympathetic innervation. I'm using diagnostic block and then pulsar ref. I have one cases of cryoablation of the sympathetic nervous system. So I don't have too much experience.
Can you do cryoneurolysis on stellate ganglion?
That was one patient when I cryoablated the stellate ganglion because the pulsar ref was not effective. Thoracic sympathectomy also. So I tried to cryo ablate, and you can do this with small probe, and you can do this.
Do you have some options for iliac wing pathological fracture?
You may start with the clunal nerves. if this doesn't work, it will be difficult because the innervation may be from the deep from the pelvis, and you may not be able to do this properly. So sometimes probably pulse RF of the TH12 L3 nerve roots may be better.
How will I access the recording of this session? That will be as well together with the recorded presentation. So you will be able to listen to the answers once again. In sacroiliac joint cryo, is there any chance to make any destruction to the joint bone?
You can also always you can make destruction to the surrounding tissue. You just need to be careful. But it is really very safe method. I am doing this. I did it thousands of sacroiliac joint cryoablation, and the main problem is hematoma because the probe is really large. And at the beginning, I was using a very thick 3 millimeter probe, and as like 2 or 3 times I had severe bleeding after the treatment, so I need to use surgical saving of the wound, and that's it.
Is it possible without using USG?
I encourage you to use ultrasound or fluoroscopy for every interventional pain therapy method or treatment method. Really, this is in nowadays. It is really shameful to do this blindly. Really, don't try it.
Does the intensive cooling cycle alter bone healing or biomechanical stability in an already compromised fracture site?
uh, that's why I think this may be not the good option for example, if the ribs are fractured, that doesn't affect because you just freeze the nerve very distal from the fracture. But I would not recommend freezing very close to the fracture because you also freeze the new tissue of the regenerated tissue, because the collateral damage is quite big. So I would freeze everything distally from the fracture.
How do you integrate nerve type selection, fascicular architecture, and proximity to critical neurovascular structures to optimize the size and geometry of the ice ball while minimizing irreversible neurotoxicity and preserving functional axonal regeneration?
Wow, very
Yeah.
sophisticated question. So uh, the sensory nerve are unmyelinated, so they are small, and you just need to know from the anatomy which one is sensory, which one is motor. You don't want to freeze motor nerves for pain. You freeze motor nerves for spasticity, and you only treat very small intramuscle nerves. You don't treat branches. You treat small, almost invisible motor branches in the muscle. So they are also very small, and the sensory nerves like medial branch or the posterior sacral network are also mainly not myelinated. You just target those nerves.
Cryoneuralize it in spasticity experience.
So I don't have big experience, but I tried it and it's fantastic. And when I saw the lecture Saturday, I'm amazed.
Yes, and when we talk about spasticity, we will have a special webinar with Dr. Jose Pereira on the 1st of July. So please stay tuned and sign up for it. And there are, oh my God, there are so many questions still, and I think we will have to choose.
Yes.
Please, what are the recommended ultrasound probe frequencies in cases of facial, femoral, and pelvic nerves?
So for the facial liner probe, for the clunal nerves and femoral also liner probe. You just need to pick the probe for the nerve. If if nerve is deep, you pick the convex.
Okay, and there are like questions, so huge. So I think,
Big short one.
yeah, so I think that will be the last one. And Dr. Ali Fatoush, we will get back to, because I can see that you've written so many questions, huge questions. So you will get the answers, like, aside, I
So
would say. So how do you safely define your ablation margins to guarantee complete neurolysis of the periosteal nociceptors without risking unintentional thermal injury to adjacent deep neurovascular structures or causing a pathological fracture due to the bone necrosis?
it is really if you freeze, for example, artery with the nerve for the for the intercostal nerve, there is no risk of destruction of the vessels, because straight away after the freezing the blood start to flow, because it acts as a heat exchanger. You won't damage, you actually want to damage vasa neurorum, because you cause Valerian degeneration, and that prolongs the duration of action. So I really didn't hear about the necrosis of the bones after cryoablation.
Okay, and how can I get a quote price for a cryo machine in Paraguay?
That's the first
I
question
will. Yes,
for you.
we've got a colleague working for the LATAM countries, and Dr. Juan Carlos, I'll send you a contact to our colleague, so you will be able to get in touch. And the last one, really the last one. Which technical parameters, duration, freeze, though cycles, target temperature, and real-time ultrasound monitoring strategies do you consider essential to standardize clinical outcomes and reduce inter-operator variability, particularly in emerging indications such as post-surgical neuropathic pain and refractory cancer-related pain?
So if you want to be like, use one setting for everything, use 3 minutes freeze time and 2 minutes defreezing time. And that's 99% of the procedure will be fine.
Okay. Thank you so much.
Thank you.
I think that we could go on with all these questions as they are coming still. So please give us some time and we will really answer.
Okay, I can answer everything. No, that's not a problem.
Yes, so we will do it. Of course, as I said, you will receive the recording of the webinar, the cleaned one as well, without any sort of issues in terms of watching and hearing. And I think that we will see you soon, Doctor.
Yes,
Yes?
I think so as well. Thank you very much.
Thank you so much. Have a great day. Have a great night.
Thank you.
Thank you. See you soon.
Bye.
Bye-bye.